Hi everybody, this is Dr. Ihab Abdurrahman Ihab Tarawa, consultant of acute care medicine at Soba University Hospital, professor of medicine, University of Khartoum. This session is part of a trauma course based on WHO course Basic Emergency Care. This session will focus on primary survey. The overall objectives of this basic emergency course trauma module to recognize key history findings suggestive of high risk trauma, recognize physical exam findings suggestive of high risk trauma, perform trauma primary survey ABCDE approach tailored for trauma patient, perform trauma secondary survey head to toe trauma exam, recognize life threatening injury, perform critical action for high risk conditions. While we are doing, or before we finish the primary survey, or by the end of the primary survey, we would like to recognize some important conditions. These are critical conditions. We need to recognize them and manage them as early as possible. Critical airway condition, it is airway obstruction. And critical breathing conditions, tension pneumothorax, massive hemothorax, sucking chest wound, and flail chest. Critical circulatory condition, this is a hypovolemic shock and pericardial tamponade. Patient with severe trauma or head and neck injury, this can lead to airway obstruction by blood in the mouth or airway, secretion in the mouth or airway, also vomitus, presence of foreign body, and also swelling of the tongue, lip, and other part of the airway. Penetrating neck wound can cause expanding hematoma. Inhalation injury by burn, it lead to airway swelling and this kind of obstructs the airway. So we have to look for any visible blood, secretion, vomitus, swelling of the tongue, presence of foreign body. If there is any change in patient voice, abnormal air sound like stridor, snoring, gargling. We look for neck hematoma or any injury in the face and neck. Look for feature of burn in the head and neck. Also assess the mental status. Any patient with altered mental status, you need to consider this could be related or it can lead to significant airway problem, and look at the chest if it is moving and if it's effective, there is effective ventilation, and look for any injury causing airway swelling. This patient should be assessed and monitored closely. They can have aspiration, suction should be done, and when we try to open the airway, we need to immobilize the spine, stabilize the cervical spine. You have to do the jaw thrust rather than head tilt chin lift maneuver, and then you need to assess if the airway is not open by this simple maneuver. Then do you need to intubate? Do you need to do cricothyroidotomy? Do you need to do tracheostomy? And then you need to assess if you are competent to do it, or you need to call someone to help you, or this patient should be transferred before critical obstruction or irreversible. Critical breathing condition is a tension pneumothorax. These patients are tachypnic and they are hypotensive because of obstructive shock. They can have distended neck vein. There is no breath sound in the affected side, and there is a hyper-resonant percussion note, and the trachea could be shifted to the other side. When there is a high suspicion of tension pneumothorax, needle decompression should be done immediately. At the same time, patient should be on oxygen. You give fluid to improve the obstructive shock, and after that, you need to see how and who can do chest tube and where to do it. Another critical breathing condition is a sucking chest wound. This can progress to tension pneumothorax. Open wound to the chest wall with air passing through. You can recognize popping or sucking noises, and there will be tachypnea and difficulty in breathing and chest pain. This patient should be placed on oxygen. You should do three-sided dressing and observe continuously to prevent dressing occlusion, and that can lead to tension pneumothorax. And then you need to assess if they need to have a chest tube, and as mentioned above, who will do it and where to do it. Critical breathing condition is a flail chest. Flail chest segment occur when ribs are broken in multiple sides. The free section move abnormally with breathing. It moves paradoxically. When the chest expands, this move inward, and when the chest recoil, it move outward, and it lead to ineffective breathing. It lead to difficult breathing, tachypnea, chest pain, and you can observe that segment moving paradoxically, part of the chest moving in the opposite direction of the rest of the chest. You can support your patient with oxygen, monitor for difficulty in breathing and hypoxia, and you need to get appropriate consultation, and sometimes patient need to be intubated and ventilated. Accumulation of large amount of blood in the pleural cavity, it leads to massive hemothorax. Patient can have a tachypnea and decreased breath sound on the affected site and dull percussion note. And also these patients, in addition to breathing problem, they can have feature of shock and tissue hypoperfusion. You need to give them oxygen. You need to resuscitate with IV fluid and blood, and and then you need to place a chest tube. With chest tube, you need to assess your competency, who will do it and where. In trauma, shock can result from rapid loss of blood, and in patient with burn because of loss of fluid. Patient with shock might have normal blood pressure because of the compensatory mechanism. It's about the perfusion, that is, there is a poor or not enough perfusion. Suspect hypovolemic shock if there is severe bleeding and sign of poor perfusion. Perfusion, usually you look at the mental status, irritability, confusion. You look at the periphery, prolonged capillary refill called clammy extremities, and usually they have no or very reduced output. At the same time, you get intense sympathetic stimulation leading to tachycardia, tachypnea. You can see pale skin, cold extremity, slow capillary fill, and patient might have dizziness, confusion, and sometimes there is an obvious external bleeding, or you can see feature of massive hemothorax or bleeding in the abdomen and pelvis with fast ultrasound. In this patient, if there is external bleeding, you have to control it immediately, direct pressure, applying a packing or using a tourniquet, immobilize and splint the limb, do use pelvic binder, make sure you have good and adequate peripheral line, use IV fluid, prepare blood, and if there is internal bleeding, then you need to plan if you can do it in your facility. For the chest bleeding, you need to put a chest tube. For pelvic, you do a pelvic binder, and for internal abdominal bleeding, sometimes they need to go for exploration. Cardiac tamponade, this is one of the critical circulatory condition when there is accumulation of fluid in the pericardial sac, and this will lead to obstructive shock. You can see feature of hypoperfusion, altered mental state, tachycardia, tachypnea, hypotension, pale skin, cold extremities, capillary refill more than 3 seconds. There be distended neck vein, muffled heart sound, and in this patient you need to have a peripheral line, a good line, and give fluid, and you need expert to drain the pericardial sac. Critical disability, severe head injury. Suspect that when there is a change in the visual field, memory loss, presence of seizure and convulsion, those with severe headache and vomiting, altered mental status, or other neurological deficit, presence of scalp wound or skull deformity, bruising to the head, especially around the eye, bleeding from the ear and nose that can signify fracture base, blood or fluid from ear and nose, and equal pupil. And for whenever you are suspecting head and neck injury, you need to immobilize the spine, and when you do exposure, you do the log roll and assess the GCS and AVPU, frequent assessment of ABCD approach, If concerned for skull fracture, you can give, especially fracture base, you can give antibiotic. Don't forget to check for hypoglycemia, and you can treat convulsion with benzodiazepine and prevent secondary injury by providing adequate oxygenation and perfusion. Remember, people who initially appear uninjured may have hidden life-threatening injuries such as internal bleeding. It is very important to reassess patient frequently using primary survey ABCD approach. You have to do that repeatedly. You do vital sign at the end, but don't delay intervention until you get the vital sign. By during doing the primary survey and by the end of the primary survey, make sure the airway is not obstructed. You don't have critical breathing condition like tension pneumothorax, massive hemothorax, flail chest or sucking chest wound, and also you want to make sure patient is not in shock and there is no suspected pericardial tamponade. Thank you. Continue another.